Now we will get started with Module 6, which will go over strategies to use when working with families. We hope that after watching this module that participants will be able to acknowledge the impacts of intergenerational trauma on a family unit, recognize the signs of intergenerational trauma, and utilize strategies for trust building and collaboration when working with families. Before we discuss specific strategies to use when working with families, we thought that it was really important to acknowledge the presence of intergenerational trauma, which has been increasingly examined in research studies. Intergenerational trauma occurs when the impacts of trauma extend from one generation to the next through epigenetics and learned behavior. And just so you know, epigenetics is where an environmental aspect impacts the genetic presentation of something, and then it can therefore be passed on to later generations. For example, researchers are finding that trauma affects genetic processes, which lead to traumatic reactivity being heightened in populations who have experienced a great deal of trauma. For example, on a biological level, trauma can influence the microglia within the nervous system, which kind of act as an immune system for the brain. And emerging literature is suggesting that when someone is in a really highly reactive trauma state, the microglia are more active and actually kind of eat away at the nerve endings rather than getting rid of damage or enhancing growth. And this actually also causes epigenetic changes, which can be passed down to a further generations. And this also results in neuropsychological dysfunction such as depression, anxiety, and even signs of dementia. Trauma can also be passed down behaviorally. For example, if a child may learn ineffective coping mechanisms from a caregiver, or they might learn kind of patterns of internalizing behavior from a caregiver who has a trauma history. Intergenerational trauma can therefore manifest in many different ways. And examples can include caregivers having unresolved emotions and thoughts about traumatic events that they therefore pass on to their child, having repeated patterns of negative behaviors in caregivers, such as a caregiver spanking their child because that's how the caregiver was raised and that's how they know how to be a caregiver. Caregivers might also have untreated or poorly treated substance abuse, mental illness, and/or personality disorders. Um, we also see poor caregiver-child relationships and emotional attachment, especially if the caregiver didn't have positive relationships when they were a child. It's a lot harder for them to therefore form those with their children. And then we also see children compensate for their caregivers' traumatic responses, such as having to take on more intense familial responsibilities in the place of an absent or neglectful adult caregiver. Further, there's emerging research that suggests that intergenerational trauma can cause significant impacts, such as increasing hypervigilance, reducing the effectiveness of the immune system, and increasing the risk for mental illness. In an article about intergenerational trauma, Dr. Gayani de Silva stated that being systematically exploited, enduring repeated and continual abuse, racism, and poverty are all traumatic enough to cause genetic changes. This means that some groups are more at risk for passing on epigenetic consequences of trauma to their offspring, including those who endure societal oppression, prejudice, and minority stress. One study, for example, found that the grandchildren of Holocaust survivors were about 300% more likely to pursue psychiatric referrals. And a smaller study found that children of Holocaust survivors had a distinctive pattern of DNA methylation, which was acting as an epigenetic marker that was being passed down across generations. It's therefore critical to examine the systems of oppression that inflict trauma and chronic stress and address them in our practice as therapists. For example, an anti-racism approach is absolutely necessary when providing trauma-informed care. When working with families in schools, then we know that it's really important to remember that children may have caregivers who have a history of trauma, and therapists should therefore adopt a trauma-informed care lens when working with the entire family unit and not just with the child. It is important, therefore, to do your best to be aware of your own judgments and emotions when interacting with families. And it can be helpful to engage in reflection on what you're seeing and maybe what you think the root of a caregiver's behaviors and strategies might be. And you can use these trauma-informed care strategies that we've talked about previously in the training when working with the entire family unit and using that to inform your interactions. We wanted to provide some examples of how trauma may manifest in an entire family unit. Some examples include a family maybe seeming emotionally numb or hesitant about trusting others or discussing their feelings. Some people may seem anxious or overprotective of their family members, even if there's no apparent threat. Some other examples include like if a parent raises their voices or maybe seems combative, it might actually be that their stress hormones have kicked in and they're in that fight mode. On the other hand, a parent who misses meetings or doesn't show up on an agreed upon time might be in flight mode and they might not actually be like rude or uncooperative. Likewise, a parent who sits silently and seemingly like tunes things out, they might just be in that response. In addition, some parents may be sensitive because of unhappy past interactions that they've had with similar clinicians or like people in your role, leading them to believe that you or other authority figures might be like working against them. And being asked to disclose personal information can feel threatening and vulnerable, especially if they feel ashamed or worried or that they're going to get criticized. Something as simple as making eye contact may be difficult or uncomfortable for some family members. And then just using a trauma informed care lens with these families can help contextualize these caregiver behaviors as you're working with them.
To work with the student's family, therapists can build a relationship of trust. On a personal level, be reliable, friendly, constantly caring, and predictable in your actions. Keep your word and never betray the family's trust. It can be helpful for a school or district to designate a liaison who can coordinate the relationship among teachers, the principal, the guardian's counselor, or other appropriate school personnel. The family and the child. Regaining trust and easy parents' fears will take time and patience. Keep an open mind and understand that a parent's negativity is open coping mechanism. Consider that family members who have had only negative experience working with the professions involved in their child's care need great courage to try once again and agree to meet with you. What a breakthrough it would be stop old patterns and form a new true working relationship with family. If family have further needs or questions, be sure to provide the necessary resources and refers for things that are out of your scope of practice. Further, to continue to build a relationship with the caregiver and to help them feel like an active member of the care team, involve them as much as possible on decision making. We know that this may be not possible for all cases in school, but try your best. Additionally, as much within your ability and scope where you work, you can promote strong, positive relationship between caregivers and children when working with the family unit. Ensure when family meets with you, they feel physically and emotionally safe. To do this, begin by greeting and talking with family members in a calm and warm manner. If English is not their first language, try to say at least a few welcoming phrases in their home language. Consider serving snacks and having water or other beverages available. If a parent gets upset or agitated during the meeting, carefully think about what you can say to deflect the situation. Avoid telling someone to calm down, which often has the opposite effect. Instead of saying something like, perhaps we should take a 5-minute break, you can say, can I get you some water or coffee? Be transparent and trustworthy. Let family member know ahead of time when and why you want to meet with them. Avoid scheduling meeting at the last meeting. Make sure family understand that the purpose of all meetings is to work together to help their child heal and thrive. Most meetings should be check-ins and where you focus on the whole child and review the child's progress. This means looking at the what is going on well and then build on the child's strengths to overcome any challenges. To further instill trust, it is vital to keep your promise as with the interaction with the children. Don't make a promise unless you can honor it. If you make a commitment in a good faith and for some reason you can't keep what was promised, apologize and then find a way to make a situation better. And then do it. Being able to depend on you is a starting point in forging a relationship that works. Share decision-making responsibility with the family members. Family engagement is all about the sharing the power. Even though it may sometimes feel you, the children's family, that you are in charge of sharing all the information and answers. This is not appropriate. If this is the case, you'll need to reconsider your approach because this shouldn't be true in either practice or appearance. Family encouragement, um, sorry, family engagement works only when there is true collaboration and each partner respect what the other bring to the table. This module 6, which describes the strategies for implementing trauma-informed care with family. Next, we'll discuss strategies for teens in module 7. Thank you.